not going to get real in-depth on this because the book doesn't get in-depth on this, and you also have a very specific respiratory section that you're going to go through. But this is another assessment tool to be aware of. It is another piece of information that you can use because we are visual learners more than anything else. There's your colorful demonstration. The percussion assessments that were talked about again in paramedic school. You see them apply here. It's just another step, it's just another level to that detailed, thorough assessment of your patient as you move through it. Neurologic assessments, again, there's nothing new, there's nothing earth-shattering here. What is this? And this is? All right, perfect. You guys are still awake. What is this? Yeah.
What kind of?
Yes.
How do you know?
Because it says something.
Really? Where does it say that?
Right underneath the arrow.
Right in the middle.
How was it called?
Why is it a subdural?
Below the arrow.
How do you know that?
See? Because it was caused by a traumatic injury.
Look at
It's on the outside.
Look at the shape of it.
No?
It does not have a distinct shape. Right? It doesn't have a distinct shape. It's very jagged and stuff on both sides. An epidural has a very distinct shape to it.
So,
And you have a midline shift.
All right, so assessments, because again, there will be somebody who teaches you this far more in depth than I'm going to because this is not my world. But what are we looking at in general?
brain.
Okay. What produced the picture? Sorry, I had a question.
CCP.
Okay, there you go. So it's another piece of technology, another step that we don't normally have that leads to a picture like this that gives us a specific diagnosis, gets us to treatments. And as Mr. Whistler so kindly pointed out, most of the time we know what things like this are because there's a physician there to tell us. You will learn that there are 4 large cavity spaces that are missing from that. And based on just the simple location of where that is, it's early because you don't really see much prominence for the facial structures on either side of it. And you also don't start to see the bony prominences within the actual image itself near the middle that would suggest it's a middle or low slice of the CT. So you have a general idea because you understand the physiology and the anatomy, and you have a general idea of what's going on with this picture, what's happening with your patient. Got a head bleed. You've got a suspicion of what's going on with it. And most of the time, these types of patients will have some type of treatment in place going on that you will be expected to maintain because you have that thorough assessment based on the knowledge and what they've given you. You're able to treat it, you're able to move it. Yeah, now I don't feel like I'm in air pockets. Gastrointestinal assessments. GIs, OBs, neurology, cardiology, pulmonology, none of it changes from your initial paramedic ACLS, PHTLS, AMLS courses. A critical care transport assessment is all of that basic information, just doing it in a slow, orderly, in-depth fashion and then using it to move forward from. This is where it gets interesting because you've got a patient that you didn't start with. You are inheriting this particular individual. And so now we go back to the assessment of the patient is done. We understand what we have to do. We understand what we're inheriting. We think that we can fit it in our vehicle, and we think that our vehicle is capable of moving it, but now we actually have to execute it. So making sure that making sure that the mixtures that we are inheriting from a facility are in our equipment, or we have the ability to do the math on them. Making sure that we label the lines that all of that is moving through. Making sure that our ventilator is compatible with the circuit that's on the patient. All of those items are things that you have to do. None of the actual assessment criteria are going to change for you as far as intervals and timing. That is, here we go. If they are critically sick, we're going to assess them how often. And if they're critically sick but stable, because otherwise we wouldn't be there, 15 minutes. Those are all familiar time frames, right? The only one that would be unusual or would be new for you guys to kind of file away is the 4-hour mark. This long distance, long duration, typically flight style transports. Although you will see some ground transports like this, where they moved a kid out of blank to Cincinnati. Children's in Cincinnati. She was a cystic fibrosis that was in early maturation at birth. Blank had Stella for I think 6 or 7 months before they finally got everything figured out, and they finally found a facility that could take care of her or would attempt to take care of her, and then they finally found a way to be able to get her to that particular facility. But can't go by ground. She's a lung patient. Got to be assessed all the time. So you get into these rather unusual assessment criteria where every 4 hours, it's not just the vital signs checks that we're doing, but you go back to that full system by system assessment of that patient and make sure that the whole picture hasn't changed on you as you move. The good news is we get it all done, we get to the facility, and we hand them off. No more magical 30 seconds of silence. This particular world, those types of handoff reports don't exist anymore. You go get critically sick patients, doesn't matter what facility you're moving them from, what facility you're moving them to. You are the liaison for two parties now, and you have to remember that when you're dropping these patients off. You not only are the liaison for the facility that you picked them up from, and responsible for providing the paperwork that they gave you and providing the story that they gave you, but then you also have to remember to give your assessment along the way. What you found, what you did, how they responded, how you responded, all of that fun stuff. So you have to tell two stories. And it can get in depth and it can get really long and it can be a whole lot of no fun. But it's relatively easy. Because it's, again, familiar to us. There's nothing earth-shattering, there's nothing overly specific. There's very little new detail that you would have to worry about. Equipment settings would be about the only thing you would really have to worry about. Otherwise, the rest of it is what has been pounded into your head to this point in time in life. The reason I say equipment settings is because ventilator settings, infusion rates, what else would there be? you wouldn't necessarily be well, I shouldn't say that because this is one of the few states, a balloon pump, because in some states, a critical care transport paramedic or a critical care transport team that includes a nurse can move a balloon pump without a perfusionist. Whatever equipment is on the patient, you need to make sure not only do you deliver the patient the paperwork and give a report on what was going on, but what you did to get them there, what the equipment required, how you had it set up. Any adjustments that you had to make along the way are also key pieces of information. It gives them another step along the way with what's going on. Proper documentation, and proper documentation is important because
That's what covers your ass.
yep. And what's the old saying with paperwork? Exactly. If you didn't write it down, it didn't happen. And it is just as important in this world to make sure that you get it all. The reason I say that is because, Lee, what was the story you told yesterday? Lung butter?
Oh, so I flew out to this little hospital and picked up a guy, transferring him to the trauma center. He's 17 years old, ejected from a car, and the paramedic was still in the ER. So he was telling me the story. He said, yeah, we found him. He was face down on the ditch. Face was in the embankment, turned him over. His whole face was full of mud, pulled a lot of mud out of him, out of his mouth. CPR, got him tubed, a couple of EPIs, got him back. So this was a Friday night. So on Sunday afternoon, they decided they were going to harvest his organs. And the trauma surgeon had read my chart. And I went in very great detail about all of that. And so he goes, I didn't know this. So he said, we better do a bronch. So they did a bronch and found out that his lungs were full of dung. And so they couldn't transplant his lungs. And so what they did was save some poor person that was on the lung transplant list a lot of heartache and grief. And that was simply because of my documentation. They would have never known that until they harvested them and then went, what's all this nasty stuff in these lungs?
Doctors and nurses are lazier than we are when it comes to writing reports. Who wants to tell me why doctors and nurses are lazier when it comes to documentation than we are?
More patients, see way more patients. Well, they have more
I will tell you that patient load doesn't matter in this particular scenario.
How long do they have the patient?
I'll tell you that that doesn't matter either. Because of computers. Everything that they have now is all preloaded. Click a box. Circle a yes, no, maybe so. And while they covered a system, there's no detail to it. There's no in-depth explanation to it. Then we go back to patient load makes that worse. We gave them all those drop-down boxes. We gave them all of those click yes, no's kinds of things because of the workload that they had. But they didn't give them a chance to explain anything. So now you go out to the middle of nowhere and you inherit this patient and you bring them back and there's limited documentation. And so you write a report like that that ends up saving all sorts of problems along the way. You know, and the details really, really do matter. And in this particular scenario, it doesn't matter if it's pre-hospital or if it's critical care. Detailed reports of detailed assessments and detailed patient care. I've killed it enough, right? Right? Detailed, thorough. Questions?
Let me add one thing to the thing about blood pressure, and that is that we are not taught this, and it's really a bad habit. And anybody that has chest pain, you need to take a blood pressure in both arms before you start getting aggressive with them. Because what's the most likely place a thoracic aneurysm is? the arch, but also branches from the arch, the coronary arteries. So if I tear my aorta right where the left coronary artery is coming off, I could look, act, and smell like an anterior MI.